Our first speaker is Dr. SIMA Das, and she is the consultant oculoplasty, orbit, and ocular oncology, head of the department of Shroff's Charity Eye Hospital at Delhi. May I request you to take over the dais, Dr. SIMA, to take us through ocular surface tumors. Over to you.
Thank you, Feroz. So I'll be talking about OSSN, the current protocols of treatment that we follow, and what are the new things. So OSSN we know has diverse morphology clinically, and the treatment modalities range from conservative topical chemotherapy, immunotherapy, and then going on to the destructive surgeries, ranging from enucleation, exenteration, and of course excision biopsy for the more advanced tumors. Histopathologically, we can classify them into intraepithelial disease, invasive OSSN, which is invading the sclera, and then going inside, being locally invasive, growing intraocularly, or going to the orbit, and then metastatic disease. So I'll just try to connect these two, connect the disease or the invasive pattern of the disease with the treatment modalities that we commonly use, and just kept it more case-based. So this gentleman, elderly gentleman, was diagnosed in the cornea clinic as having an herpetic dendritic keratitis, as it looked like a stippled epithelial involvement which was running in a linear fashion in the inferior half of the cornea. But what is important to note is that he has this small nodular lesion which looks like a keratin plaque at the limbus. Another patient diagnosed as Salzmann's nodular degeneration because of this white nodule-like lesion involving the corneal epithelium. But if you see under slit lamp retroillumination, what is very apparent is that the lesion in the epithelium seems to be well demarcated with fimbriated edges. Yet another gentleman, he was seen in the clinics because he has initially consulted somewhere else where an applanation tonometry was done, and he came back following an epithelial defect post that, which was thought to be because of the applanation, which maybe was not done correctly. So when you stain, there is staining with fluorescein, but what we also see is that stippled involvement or appearance of the epithelium, which probably is because of the keratin which is there on the surface epithelium. So all these are variants of the corneal OSSN, corneal epithelial involvement. And the typical feature here is the fimbriated edge, finger-like projections. And if we see carefully under slit lamp, we will also be able to see the small blood vessels which are there inside the lesions. So for corneal epithelial involvement by OSSN or any surface OSSN which is still in the epithelium, ASOCT is now the investigation modality of choice, which we do for every patient before starting the patient on conservative management. So ASOCT has very specific features involving an abrupt hyperreflective thickened epithelium, which kind of, there is an, do we have a pointer here? Do you have a pointer? Yeah. So there is an abrupt transition from the normal epithelium going on into an hyperreflective and a thick epithelium, and we can clearly see the, here we can see the lesion is entirely confined within the epithelium and underlying basement membrane seems to be intact. So these are the lesions which are typical good candidates for topical immunotherapy or chemotherapy. If you want to confirm further, we can do a little bit of scraping from the epithelial lesion, do the GIMSA evaluation of the slides, and you can see the atypical cells, which is again further confirmatory. So intraepithelial disease like this, if we diagnose, topical therapy is the modality of choice. There are various modalities or various protocols which are followed for topical chemotherapy and immunotherapy. MMC used to be the drug of choice earlier, and generally the protocol which is followed is 0.04%, 4 times a day, 4 days a week for 4 weeks, but there are many other protocols which can be followed. Interferon came in between, showed a very good response without the side effects which are typical of mitomycin C, and now generally 5-FU have also been found to be a little more effective than interferon with a little lesser side effect profile than mitomycin C. This is one of the patients which is predominantly involvement of almost 10 clock hours of cornea, which cleared up significantly with just topical mitomycin C, leaving behind a clear cornea with not too much of scarring. The same gentleman that we see had the cornea totally cleared up after interferon. So we have to understand one thing, that before we start the patient of topical interferon, we have to ensure that it is an non-invasive disease, means the disease is confined to the epithelium, not breaching the basement membrane, unlike here where there seems to be some breach in the basement membrane and the disease seems to be going into the underlying stroma of the conjunctiva or to the corneal lamella. So if that is there, then it's a contraindication for topical therapy. Sometimes even in a lesion like this, where there is too much of keratin on the surface and a little thick lesion, it might not be possible to see the underlying basement membrane on ASOCT. So if there is any doubt, it's better to go ahead with excision for this kind of lesion rather than starting on topical therapy. I'll skip the video. So these are usually the corneal variant of OSSN. There are a few other variants which can also be a little more aggressive. The atypical variants like a diffuse blepharoconjunctivitis, where there is involvement of the sclera with a lot of thinning. This was a pigmented OSSN in an HIV-positive patients, and a nodular variant which tends to go more deeper than come more towards the surface. These are also typically seen more commonly in the xeroderma pigmentosum patients, other patients with immunocompromised state. This was a young patient with a corneal OSSN, which was covering almost the whole of the cornea, which we can never be sure whether it's going into the stroma of the cornea or not. So these are the situations where you might have to do an pre-op UBM and might have to be prepared for a little more extensive surgical excision than just a simple excision of the lesion. So if required, we can go for a lamellar keratectomy or a sclerectomy for this patient. Generally, if 2/3 of either the sclera of the cornea seems to be involved in OSSN, then lamellar keratectomy or a sclerectomy can take care of the base of the lesion and ensure that we have a clear base. Patch graft is to be avoided mostly in this patient because if there is a recurrence beneath the graft, it's difficult to detect, then it might go unnoticed and go intraocularly. The same patient, we took help of the cornea colleagues. They did a lamellar keratectomy and he did have a clear cornea in the postoperative period. I will again skip this video. Another patient where a sclerectomy was done. And this is what is important, where you see the histopath, you can see the scleral lamella at the base of the lesion, which seems to be free of the tumor. So this tumor was excised in toto along with part of the scleral lamella. So invasive OSSN, surgical excision is the treatment modality of choice. Along with that, we always do cryotherapy to the margins, to the base, and we always ensure a base clearance. But there are some situations where the base might not be clear. Like in histopath, we can see there is scleral lamella. You have already done a sclerectomy, but there is tumor beyond that. So you have left behind some residual tumor, microscopic, after the excision also, and this patient needs to be treated with additional adjuvant therapy. Most commonly what is used is plug brachytherapy. This is one of the patient who was Dr. Anirban's patients. In fact, she was operated and the base was positive, but the residual tumor, we did a plug and she's doing pretty well on follow-up. Another patient, again on UBM, we can see there is some involvement of the sclera. So till the time she was waiting for surgery just to do a little bit of chemo reduction so that your surgery is a little less extensive. She was started on topical mitomycin C and she responded very well to topical MMC. So that's the time we thought, why go in for an excision? Just go ahead with a primary plaque, and a primary plaque was done for her. And I think it's more than 1 year follow-up now and she seems to be doing fine. So there are situations like this where there is too much of involvement of the sclera, more than 2/3, and here it's very clear invasion of intraocularly. We can see it on UBM going to the ciliary body area. CT also confirms the same. There is a breach. And these are the patients where you definitely have to go for an enucleation. So what are the signs that the tumor has gone inside the eye? There will be some anterior chamber inflammation. Gonioscopy will give you some clue. High intraocular pressure could be one of the indicators that this tumor might have gone intraocularly. So if you suspect in any OSSN patient that it might have gone intraocular, it's a good idea to look for these signs. Another patient where it was referred as a perforated corneal ulcer for evisceration, but if we see carefully, this is the residual area where there is keratin plaque, and this was probably the tumor involved the whole cornea and caused a corneal melt. So these situations where there is an intraocular invasion has to go for an extended enucleation, which is little more than what we do normally with a clear conjunctival margin. So what I mean is that when you normally do the enucleation, you do a peritomy 360 degree. Here your conjunctival incision should involve the whole area with a clear margin involving the tumor area. And then we proceed like a normal enucleation. This was the same patient. You can see the involved OSSN with the conjunctival margin, and then the eyeball is taken out along with that. If there is an orbital invasion, these patients have to go in for an exenteration, usually an anterior orbital exenteration. And rarely, OSSN is generally not a disease which is very invasive or kind of metastasized beyond the local areas. But sometimes this was a small tumor in the eye to begin with, not very big, but at presentation, this gentleman had an preauricular lymph node involvement, which was positive on FNAC. So possibly these are some of the variants which are more aggressive. Maybe the tumor biology plays a role here, and these patients We don't have very good treatment modality available to cure, but there are now new targeted checkpoint inhibitors and other therapy available, some of which are now available in India, the PD-1 and the PD-L1, the CTL4 inhibitors, the pembrolizumab and the ipilimumab, the tongue twisters. So at least it can increase the lifespan for some of these patients, but it is expensive. Most of them are not able to afford it. So if there is a possibility, we can offer this to some of our patients. So just to conclude, careful ocular and systemic evaluation is very, very important whenever we are seeing a patient of OSSN. Not everybody is a candidate for topical therapy. Please select your patients very carefully, which are surgical and which are medical management cases. Imaging modalities like ASOCT and UBM helps a lot. And histopath has to be seen very carefully to ensure that there is no residual disease. So thank you very much for your attention.
Thank you, Dr. SIMA. Do we have any questions for Dr. SIMA from the delegates? Anything regarding conjunctival tumors, need not be OSSN, and she manages the entire spectrum of conjunctival tumors. Anyone? Dr. Anirban, anything that you want to comment on your experience with conjunctival surface tumors? Right.
To know whether it is reached the placement membrane before we even think of topical chemotherapy is, I think, the most important point that she's made.
Right.
Apart from that, she shared some of the cases where we worked jointly, where there's been scleral deviation and our practice has been taking care of those patients and we've been able to salvage those cells.
Right. So, Dr. SIMA, I have one quick question for you. So, when we use interferon, I'm sure you use it in your practice, we also use intralesional. So, is there a particular set of patients where you would use a combined topical and intralesional, and in a set of patients where you would use only topical?
So generally, I tend to use intralesional. One is it's an extensive disease, or if there is a diffuse OSSN with some nodular component within it,
Yeah.
or if you feel that the patient will not be able to come for a very regular follow-up,
Right.
or the cold chain maintenance might not be very kind of reliable.
Right.
So those patients, instead of letting them put the drops, maybe an injection is something which might hasten the process of resolution, especially if there is a diffuse involvement with nodular areas. Simultaneously topically started, but in those nodular areas we can simultaneously inject also.
Okay.
So generally these are the set of patients where injection is given.
Okay. And what is your experience with 5FU now that everyone is like, talking about 5FU?
So it is something in
yeah.
between in terms of efficacy. It's probably more efficacious, more faster resolution than interferon, little lesser than MMC.
Yeah.
But I think one or two patients we had bad experience with the corneal epithelium.
Right.
Stromal melt. There was one patient
Stromal
who had
melt?
stromal melt.
Okay.
So
and your dosage is
dosage is 1%.
1%.
4 times a day for 1 week.
Yeah.
There was one lady. Now she had some pre-existing corneal epithelial disease. There was disease in the other eye also, bad ocular surface. Now whether that predisposed her to that, but she had a stromal melt. So somehow she recovered, but there was a scarring of the cornea.
Okay.
Otherwise, it definitely is more faster resolution than the interferon. And the side effect profile, the ocular surface side effect profile is probably a little less than the MMC.
MMC, right. Yeah. So your first choice would be what?
Right now, our first choice is a 5FU.
5FU,
but
okay.
we monitor the patients a little more closely now after that experience.
Okay.
If there is any epithelial disease, then generally we tend to
Is there a particular reason why you would choose 5FU as your first choice?
Interferon, one is the cold chain. So that's
the cold chain, right?
Cold chain,
yeah.
Especially, we are in North India. So that part of the country, 8 months of the year is sort of, and the patient profile, many a times the kind of patients which comes to
Poor
us, they
patient.
sometimes,
right.
don't have any access to the cold chain at times.
Right.
And the distance.
Right.
So that's one of the reasons.
Okay.
MMC, of course, the side effect profile is something which you don't want.
Right.
So that's the reason we have shifted as first line to 5FU.
Okay.
And then if there are any other reasons not to give 5FU, then ocular surface is already bad and all, then interferon.
Yeah.
MMC is the third.
Perfect. Dr. Santosh, what is your worst side effect that you have got with 5FU in your practice?
Which was refractory, non-healing. It took tarsorrhaphy to heal.
Okay.
So that's about it. Otherwise, it's a safe drug.
Okay.
And that was a patient who had severe dry eye as well. So we should select
out patients where there is no ocular surface issue or corneal issue, then it's safe. It's not as much as mitomycin.
Right. So one of the side effect that I have noticed with 5-FU is canalicular inflammation, like a canaliculitis, like, and the patient started coming with tearing of watering, epiphora post 5-FU, but then put on steroids, possibly the inflammation settled down and the patient was fine.
Any
Yeah.
stenosis? Post?
No, post there was no stenosis, but on treatment the patient was having epiphora and stuff and severe pain when I did a probing. So that was causing a canaliculitis in that patient. Yeah, inflammatory canaliculitis. Put the patient on steroids and the patient recovered well. Yeah.
Blepharitis is again another thing.
Yes, blepharitis, especially in the corner,
you do
they
see
get
most patients.
yes, in the corner, yeah, near the medial canthus they get it. Right. Yeah. Anything else? Okay. Yes, Dr. Senthil.
So we give, once the visible lesion is gone on rose bengal staining also, we keep it on for about 4 to 6 weeks. So another month or so, just to ensure that there is nothing microscopic which is remaining. Usually 2 to yeah.
Thank you, Dr. Seema.